So that is a Hill-Sachs lesion. And it depends, you can do Hill-Sachs first or do it later. But I think as your comment yesterday, you said you do first. I agree. Because when you do the Hill-Sachs first, you have more space. See? You can push the arm to the front and you have more space to work, right? But Prof. Adinan, has no problem. He can do this later. But I think the space would be limited when you do this later, okay? So the next step is before I start my label, I will do my Hill-Sachs first, okay? So let's see the labrum. I'm showing you some label pathology, right? So we always detach our labrum to the 6 o'clock position like this, right? Because in the shoulder instability, we like to lift up the inferior pouch also, not just anterior. So every shoulder instability, that's just not anterior instability. They have combined anterior and inferior, okay? So every time we need to start your labral detachment starting from the 6 o'clock, right? So that is the benefit of this position, right? In big chair, you will have difficulty to reach this area, right? In big chair, yeah. So you can repair it starting from here, but in the case that have very bad instability, I think you can start from this 6 o'clock. That should be better, okay? And also in this position, you see that you also can manage your posterior labrum, right? No problem. So in one position, you can do all around, right? This is the posterior labrum, okay? That is 6 o'clock position, okay? So before you're doing the instability work, I think first you need to make a nice labral detachment, right? So we prefer to use the Bankart knife, yeah? Detach the labrum, very gentle, yeah. Suction, okay. And then we're starting from here. So for the Hill-Sachs, we try to, oh sorry, cannula, look. Okay, okay, good. So we can do this. Okay, we have one anchor here. Okay, this way, yeah, that's good. Okay, see the trajectory. Okay, mallet, go. Okay, very good. And then we twist in. So the rotator cuff anchor, please. Okay, give me anchors. Yep. That's good bone quality. Okay. Okay, nice. Okay, good. Yep. You have good feeling. This is the suture and the tape, right?
Yes.
Nice. Okay, we're getting close to the cartilage. Okay, go. Yep. Yeah, please. Okay, hold camera for me. Make sure that it's not penetrate to cartilage, right? Always looking at your trajectory. Go. Okay, make sure that you're not penetrate to the opposite cortex, right? Okay, it's very good bone here. So if the patient have soft bone, you also can use the soft anchor, right? Depend on the size, right? If the Hill-Sachs lesion is big, we use the 2 anchors, one on the top, one underneath. Okay, but it's the small size, we use the 1 anchor. Most of the time we use 2, yeah, because most of the Hill-Sachs that was engaged or off track is a big Hill-Sachs lesion, right? So now we have 4 sutures, right? My trick is that I will take the BVTM side. We're starting here, okay? You see that we are outside the capsule now, and then you pierce this one, right? Like that. Okay. This one through the capsule. Okay, that's good. Okay, and then you throw the sutures. You also can use bird beak. Okay, but this way I can move easier. Yeah. Then the first one we take only one suture. Okay, this is the tape, right? Yeah. So you put this to the front. Yeah. Like that. Hold this for me. Okay, like this. Okay, make sure that it's not out, right? So this one you can have better. So your bite should not be too far from the insertion because you have over tight capsule, right? So now the next one I will pat 2 sutures, right? The first one is 2 sutures. There. Okay. Always look at your ankle. The suture is not moving. Okay, that's correct. Okay. So the bird beak is fine, but bird beak when you get in, you need to manipulate. Sometimes you create a big holes in your capsule. Okay. But this is less low profile. Okay. This is the suture from the first ankle, right? We take this one, and we take one from this. Okay. Because the color is the same, you make sure that you're not confused. Okay, this one and this one, yeah. Push this to the front, 2 เส้นนะ Yeah, this one, okay. Oh, that's good, yeah. That's nice, that's just a loop. Okay. Yes. So we will have the, yes, nice, okay. So Niva, now this one, okay. This one is not passing through, yeah. Suture retriever. Okay. Okay, that's good. Okay. Okay, last bite will be here. Yeah, here, last bite into my infraspinatus here. Okay. Okay. So once you tie the knot, right here, you will close the gap now, right? So we tie the knot, this knot after you finish your label repair, okay? So now coming back to our label repair, okay? Do some stitch here, okay? For the labrum. Chima, some trough. Okay, I press. Okay, on the edge of the crinoid. Okay, we make a nice raw surface on the crinoid. If you have the culate or ring culate, that will be good, right? Because we want to have the nice raw surface on the crinoid side. So once the healing on the crinoid, that will be nice, okay? Oh, that is a rash, okay? Yeah, you need to have the very nice tissue preparations here. Try to, yeah, try to go, yeah, like that, yeah. Mallet, go. Okay. Don't worry yourself to the nerve. If you're close to the crinoid, no chance to injure the nerve. The nerve is there, right? If you're close to the bone like this, you will save, right? So make sure that you have very nice tissue preparation. You're going to the crinoid neck, right? And try to make a nice preparation on the bone, right? So this is important because many times your Bankart is like chronic one. You have the very tissue retraction or very bad tissue. So important to make a good preparation, right? I always going down using the rest, okay? Going to 6 o'clock position. Yeah, it's same like you do the shoulder replacement, right? You can go around the glenoid without injury to the axillary nerve, right? Now coming from the front, yeah. Make sure that you have nice preparation. Yeah, you can, yeah. The burr, I think we can use that for the, on the edge, right? Identify the edge. Okay, here. Okay. That's easier because this is normal labrum, right? It's not easy to remove the labrum. But in the real patient, it's much easier. Okay, yeah, that's good, yeah. Yeah, like that, yeah. You try to release that, like that. Okay. Some rest. Okay, you need to see the glenoid neck. Okay, rest, please. But in the real patient, it's much easier, yeah. Okay, okay, that's good, right? You need to move this way, yeah. Don't worry, you will have very nice tissue mobilization, okay, like this, in the real practice, yeah, like this. You need to elevate your labrum, make sure that you have nice elevation like this, right, before you start to do the labral repair. I think this is the key, right? Because sometimes you're not aggressive enough, yeah. For the tissue mobilization, I think this is the key of the success, right? Here, okay, nice, and then going to 6 o'clock, okay, it should connecting, yeah, like that, yeah. Connecting to 6 o'clock, okay. Nice. Now, your tissue mobilization is good, yeah. So keep in mind before you start, you need to have the nice tissue preparation like this, right? Shaver. But in real practice, it's much easier because the label is already detached. Okay. Nice. And we always start from the posterior portal first. Sometimes you can see some patient, the label tear is extending to the back. Yeah, have you seen some? Yeah, it's like very bad Bankart, extending to 6 o'clock, sometimes to 7 o'clock, right? You need to make sure that you have a nice tissue preparation. So I start with this first, right? Now you have a nice tissue preparation. Always start from the back, don't from the front, because from the back you can stitch to the 6 o'clock. And this portal is very useful, right? 45-degree curve, right? Yes. Someone use a posterior as a viewing portal, but the view is not so nice. If you want to see from the middle, you want to see symmetrical view, you're looking from the top. Yeah, so like this view. But you can use this portal once you finish your job, yeah, in the inferior. When you start to do the top, you can switch your job from this portal to the back, okay? So here, so you can start. Don't worry, you make a very big bite like this, always, right? Like this, make a big bite. Okay, Casper, suture retriever. Anchor, please. Okay, nice. Very well. It's just cleaning. Okay. So I like you to use the soft anchor. The joint fix. Yeah, we're starting from here first. This is 7 o'clock. Okay. Okay, nice. Take it out. We outside out. Yeah, fish mouth here. So make sure that you're good here. Okay. So vipa. Yeah, let's go.
Bending it a bit. Yeah.
Stop. Nice. V. Go.
Like this.
Gentle.
Can you hold it a bit higher so you can fix it over here? And now
Turning.
2 clicks. 1.
Okay, very nice. Yeah. So that's become a ball. Yeah.
Yes.
That's become a ball. Yeah. Abhishek. Yeah. Very nice. Oh, sorry. Oh, the bone is soft. Yeah. Nice. Okay. Very good. Yeah. You see that? I showing you, I pull, right? This is strong. Yeah. So this is a good because it's become like a ball underneath the subchondral bone. Yeah. Okay. Showing you. Let's go.
Sorry?
Yes. And now we take this out. Yes. Puppy. Okay. Yeah, not pusher. Yeah. Okay. Nice. So now you get the important stage. This is 6 o'clock stage. It's a very good to hold the axillary pouch. Okay. Can you help me? Yeah. Okay. Nice. And maybe hold the. You can use sliding or not. I actually I don't like the sliding knot in the shoulder instability because when you slide the knot, you have too much load to your ankles, right? So I just use the simple lever knot. But that depends, but I don't like to slide the suture into my ankles, right? You see that here? Very nice. Okay. We throw 5 throws, right? Now 4. And then we need to switch the post. Here you go. You look at my post. I need to switch. You see here? Switch the post 1 time. See? You need to switch the post 1 time, at least. So that will make your ankle stable. Yeah, the knot security would be better, right? Yeah, right. Nice. Okay. So that is my, I prefer to go 5 throws. Yeah, here. Very good. Cutter. Nice. Okay, that's fine. Very nice. Okay. So that is my first stage. Okay. So the second stage also I can come from the back. I show you again. Left. Okay. And after you go from this stage, you can move your camera to the back. Okay. Like this. Okay. Don't worry, make big bite. Okay. Very big bite. Sometimes hold this. Your assistant may help you to go, okay, and lift this up, okay, so you can see better. Yeah, you can use the something like scorpion or what you call in Rejoin, the same like scorpion, huh? What you call the same like scorpion? You have it?
Yeah, easy pass, but only for the cup.
Yeah, you have it.
Not for cup, yes.
Oh yeah. Let's show. Yeah. Okay, let's try. Here I'm showing you. Here, you see that? You happy with that? See? You see how big is your bite, right? See? Thank you for your advice. Yeah, that is nice, and I think everyone love it. Yeah. You love it?
Yeah.
Easy, right? Yeah.
Okay.
Yeah, please. Okay, good.
Yeah. Yeah.
Okay, nice. And this will be your neck shuttle, yeah? Okay, suture retriever. I put 1 from this side. Okay, this one. Okay. So this will be your shuttle, okay? So neck anchor. Now you can grow from here. This is the edge, right? So here should be fine. Mà hiểu không đi? Thôi nó bị nó ช่วยต่อกันยัง Okay, that's good. Let's go. Go. Very nice. Very good. Stop. Go. นี่ไปกดไปกัน Okay, and then turn. Here one pop. One pop. 1, 2. Pop. Okay, that's it, right?
Yeah, exactly.
Make you excited to pop. Okay, that's nice, eh? And now not confused because it's the same color. Okay, I will not confuse. So this one is the shuttle, right? Okay. And this one, you're not confused, right? This one together. Okay. Yeah, confused now. Do not confuse. Okay. Okay. You okay with that? It's correct? Okay, this is a shuttle. Go. Very nice. Suture retriever. ถูกหน้านะ Okay, I can tie from the front. อยู่หน้าหมดเลยฮะ Okay. So before you tie the knot, make sure I always put my suture retriever to make sure that the suture is not tangled in the, hold this for me. Okay, very nice. Okay. Okay, very good. Yeah, nice. Because I don't want to load my anchor. You can use, but once your suture is sliding in anchors, there will be some pulling. Yeah. So depends if you like it, it's fine. Yeah. But if you have like soft bone, I recommend you not to slide. Yeah. Because once you slide, you have some pulling of your anchor from the bone, right? Okay, that's it. Now you manage your labrum at 7, 6 o'clock now, yeah? Okay, switch pose, cutter. Okay. Nice. Yes, okay. Good, okay. So now you can switch your camera from here, right? Looking from the back, yeah? Because sometimes you're familiar with that, right? Here, now, here, you can come in from the back, right? And then you can repair. That is the MGS shell. You can see that? That's one MGS shell, okay? So I make another bite, and then I come back for Remplissage, okay? I think I will show you about this, that's fine, okay? And then you can do some practice. And now I come in to do my Remplissage, okay? You see my camera is here. Bicep, you know. Where's my bicep? Oh, yeah, we are behind the bicep, right? Okay, that's good. And then I switch. I think that's enough. They can practice. Okay. So from here, right now, you see, and we take this out, yeah. I will make the, Remplissage, okay. So before you tie, you need to see which suture is the first one, right? Okay, that one is my first one. Okay, we have done that. Okay, so that's my first sutures. Okay, okay, attention. Okay, that's one, yeah, but that's my first one. Okay, yeah, we remove the cannula now, yeah, and then we tie the knot one by one, right? So it will be like mattress, yeah. So that in my first suture, I put the knot in this one and this one, right? You see, it's the same one, okay? And then the last you need to slide it to sliding, yeah, okay, and clamp, yeah, keep it together. Yeah, make sure that the suture is nicely. You see that? I We'll try to tie my first one. But this one, I can use the sliding knot. Yeah, here, yeah, we just put this in. You see now? It starts to close. Always close from bottom to top. Because if you close the top first, you cannot see the bottom, okay? You should close from bottom to the top. Now I'm on the cap. I am the rotator cuff. I can feel right here. Yeah. Nice. Okay. Here. Make sure that you are close to your rotator cuff. Previously, we go into the subacromial space. Okay. But I think too complicated. Yeah. I have tried both ways. We have no difference. So this is easier, right? You just tie it. You make sure that you can feel you are on the rotator cuff, okay? Cutter. But careful when you cut it, not cut your knot. Yeah. Yeah. You push it in until you feel your knot, okay? Withdraw a little bit, 2-3 millimeters and cut it, yeah? Okay, you see, it starts to close. Next one. Yeah. Good. Yeah. Here, every time you need to slide your suture first, you see? It's good sliding. Nice. Okay. Okay, hold this. Key is that you need to slide it every time because you're tying the knot in blind, right? Here, starting. No, in this same position, no. And we found that even you do Remplissage, you didn't have no problem with the range of motion. Okay. There's no difference even you do Remplissage or not. Yeah, in our study. I think traction is not the issue, right? Now you're coming back here, right? You see that it start to close your gap now. See? Yeah, start to close your gap now. Yeah. The last one, can you hold like that? Yeah, very good. Yeah. This is my last bite. Okay. Yeah, shaking. Yeah. And then the last bite. Now you see that the effect was closed now. You see? Completely closed. See? Completely closed. Yeah. Nice. But you should not make a too big bite, into the defect, because you will have too much tension. So you calculate how far is your defect from the capsule, right? And then you should bite at the same level. Yeah. Okay, like that. Yeah. So now we close the Remplissage. Yeah. Ada? Okay, that's it. Yeah. So here you see you close your Hill-Sachs lesions, right? And also now you repair your labrum back. Yeah. Okay.